that. I'm excited to have this conversation, and I appreciate the invitation to talk about this project. I did a little time, well, most of my career has been in higher education, but also been heavily involved in community engagement work and qualitative research. I think it's important to get out there and just get the real narrative and the context for how issues and challenges really impact our communities. And so this was an opportunity, this bidirectional crisis and emergency risk communication framework we adopted from Mayo Clinic in Minnesota with Mark Whelan and his team with efforts that they were doing. And so I'm just really excited to share with you all how this project went. And so some of the objectives we want to try and hit this morning is to understand the importance of leveraging community partnerships and developing credible risk messaging that improve preventive behaviors in rural communities of color. And so when we think about those partnerships, we understand that in many cases, when I was at the University of Mississippi Medical Center, I was in the Department of Population Health Science. Prior to that, I was in elementary and early childhood education, but that's a whole other deal. But we understand that it was really important to get out there and get the narrative because so many things were happening at the height of the pandemic and particularly impacting rural spaces, and we just didn't have a lot of guidance. And so we want to also look at how to increase awareness of community mistrust and mitigation behaviors and its impact on COVID-19 transmission in rural communities. And we really want to talk about how community mistrust sort of landed in the areas that we were really trying to do this work, and how medical mistrust sort of intersected with how messaging was, not aligning, and it sort of snowballed into something really different. And we want to really try to understand how historically marginalized communities can adopt preventive behavior when messages are crafted and delivered in a language and modality that are culturally congruent and resonate with them personally. And I'll talk about how we started to do some of those things in our messaging. And a sneak peek on that is that one important thing we did was we really tried to filter information that was coming down from CDC and those places that had guidance material out there. And we used a graphic designer to really make more infographics and less heavy print material to get out into rural spaces. But we'll talk about that shortly. And so the project. So this project was mainly focused on health communication at the height of the pandemic. And when this first started in 2020, my department chair came in and he was like, how can we start to really look at this and for, this pandemic and understand how it was impacting communities. So initially we thought, I'm based in Mississippi. And so we started looking at, maybe we'll look at North Mississippi, Central Mississippi, and Coastal Mississippi, and really try and understand how this is landing in each of those spaces, but that got a bit expansive. But we started to use the CDC CERT framework, the Crisis and Emergency Risk Communication Framework, and we started to pilot it in several rural counties in the Mississippi Delta to sort of establish this bidirectional communication. And I'll talk about more what bidirectional communication really looks like on the ground for this work, because we understand something fundamentally that in a lot of spaces, higher education may not have the best reputation, right? Universities are not really coming into these areas and always collecting information, always collecting data. And many times community members say, why should I participate in this? We just did a survey, we just did a study, we just did a focus group, and we don't know how this actually moves the needle or changes anything in our lived experiences. And so we understood that. And so we tried to get out there with a model that helped to leverage the influence of actual residents within the community to be the messenger of accurate information to disseminate out back into these rural spaces, because it was not getting there, and understanding how residents were actually getting information was an important part of this process. And so in this bidirectional communications model, we were actually trying to, in our rural communities, address questions, generate ideas, and learn about new issues and barriers from the community as we were disseminating out. So as we were putting information out, our team was actually collecting the impact of that information weekly. And we'll talk about how that looks a little bit later. So again, when we talk about Rochester Healthy Community Partnerships, Mark Whelan and his team, they had like an 18-year community-based participatory research model that they were working on. And they were gracious enough to jump on a lot of team calls with us and help us develop strategies so that we could adapt their model to actually implement it in the Mississippi Delta. And so it sort of looked like this. With this, we had our teams that was both collective but individually functioning. When we first started, we had our core academic community partnership that consisted of, we sort of made a list of who all should be at the table, who's on the ground doing this work. And so we did an environmental scan first in each of the areas that we were working on to try to understand who were the faith-based communities, who were nonprofits, who were, school districts and community leaders. And then we combined them, representation with them, with our academic team within the Department of Preventive Medicine, Population Health Science, Data Science in the School of Population Health at the Medical Center. But then we also had our community partners. Our community partners, we had one per county. So we were in actually 3 counties in the Mississippi Delta. So each county had a community partner that was designated as sort of a broker to go into community and sort of vouch for us as a viable option to start doing messaging and COVID work in their community. We got these community partners by starting with a series of listening sessions. We did about listening sessions all over for about 6 months before we even got funding, right? So we wanted to have a really great understanding, and note that I'm saying we did listening sessions and not focus groups. We didn't want to go in with this pre-prescribed series of questions where we were just collecting data. We really wanted each one of those sessions to be driven by community perspective. And then we did not choose the community partner. The residents chose the community partner that would be representing them. And each of the 3 counties then had 5 communications leaders. And so those communication leaders were actually giving messaging material to disseminate out weekly. And they had a log that would generate their impact or what their reach would look like. And we would have weekly meetings on that to try and understand. And so it required a lot of meetings, granted, because when we looked at this, I was meeting with the communications leaders for each county on weekly, bi-weekly, the community partners to understand how everything was moving along in terms of facilitation. And then the steering committee I was reporting to on monthly. And so to understand if we needed any more resources and all of those things. And so we settled on the 3 counties that we wanted to work in, and they were Holmes, LaFleur, and Washington County. All 3 had a really high population of African Americans in those rural spaces. And please note the poverty rate. So anyone with any familiarity with the Mississippi Delta know that there is a really high concentration of poverty, but each community, it has its own separate set of challenges. And so in those initial listening sessions, we learned a lot of different things. And so we went in with just some guiding questions. And one of those questions was just generally, where do you go to get information? What's a trusted source of information? And who do you lean into? In some spaces, it was the church, it was the pastor. In some spaces, it was not. It was mainly television and radio. And understanding that many of these households did not have broadband to actually get some of this information. And those that did, it depended on the age range of those participants. And so when we thought about messaging and who would be communications leader, there was a wide range. We had senior level folk, older adults, we had younger millennials, and each one of them would disseminate information out to their network based on their best avenue for getting the information out. And so we'll talk about what that looks like. But in adapting this model from Rochester and Mayo Clinic, the adaptation of the intervention by the community academic partnership in those 3 counties, we really wanted to try and assess the number of messages delivered by communications leaders. So like, for example, our communications leaders, if I had an older adult, I didn't expect the older adult to be sort of on Twitter and Facebook doing messaging, but the younger population did. I didn't expect the older adults to do Insta stories and those kinds of things with the messaging that they had. But understanding that when we were thinking about messaging, there were new things coming up every week, right? And so if this week we're focused in on just guidance and prevention, uh, and how that looked, initially, when you really think about it, there was not a great deal of information. We were like mask up and 6 feet apart and all of those things. But rural communities had a specific set of questions, in terms of, if you have multi-generational homes in a small space, how are we supposed to social distance? If grandma is also in the household, what are some prevention measures that, if you have as young as a 6-year-old that can be asymptomatic, and an older adult that's in the household, what are some prevention guidance that we needed to get? And so we would have these conversations on what was resonating with residents each week, and then we would try to craft messaging or get print material or make infographics to sort of counter whatever that narrative was. And there was a great deal of misinformation that was floating around out there as well. And so when we think about how that moved, and if we needed a larger sort of thing that we wanted to get to, we didn't just do messaging. We also held I did Facebook Live conversations with a physician to answer questions in real time, and residents would invite their folk to do that. But also the graphic design person, instead of, if you didn't want to watch that 45-minute, interview, he chopped it up into segments so that folk could get it in snippets that is labeled by the question that was posed, and you can get a direct answer to that just by clicking on the link. So we tried to understand how residents were getting information, because as information started to get out there, there was like an interpretation of that. And many folk wanted to say that, oh yeah, there's the Tuskegee incident, that, thing that happened, and that's why residents don't want to, be engaged in so on and so forth, particularly around vaccination. Well, that wasn't exactly the case with the residents that we were talking to. Many of them were already having less than, they didn't have the best experience with health professionals even prior to the pandemic that they had experienced themselves. So there was already sort of a breach of trust within those communities with the areas that they have access to. There's a big conversation in rural communities around having access and how to health care and health professionals, and how the quality of that access looks that impacts whether or not they actually use it. And so you can have a physician that's within your community, but if people don't have the best experience with that physician, they still would rather travel to another facility to get better services. So having access to doesn't mean that residents are actually accessing that particular point. And so that sort of showed up. And so when we think about the model, this is the intervention framework. So we were really out there talking about, in that first leg, we were talking about the COVID-19 prevention and containment component, and how we could get risk communication messaging out there with the communications leader. And we were also trying to do a health assessment, around COVID-19, and address any of those questions and concerns, because there was social and economic impact of COVID-19. And this includes food and housing insecurity. So many rural communities heavily depend on food banks, food pantries that are run within the community. All of those things were shut down, at the height of COVID. And so it had a really significant impact when you're relying on those things and you're already in a situation. It sort of blew it, to another level. So we tried to refine messaging according to the changing facts of the community. And we tried to leverage those resources to meet community needs. And we did on the steering committee, on the core academic advisory component, we did have state officials that were a part of that group that we could feed that information to, that we were collecting from the community. And so a great example of that was when we were collecting information when vaccines were first starting to become available. And they had where older adults were eligible, but they had to go online to sign up for it. Well, many of the older adults didn't know how to navigate the platform to sign up, and they were using a younger person in the household to register them. And so we were giving that information to the State Department of Health, and they actually sort of changed that up, changed the page up a little bit, made it more user-friendly, and then put a 1-800 number out there where residents could call in. So we were collecting that information, and they were making adjustments as we were getting that information on what residents actually needed. And again, we were amplifying that community voice, right? Those listening sessions were a really important part of the relationship building and the trust that we were coming into. And it was really proactive because we didn't do it when the pandemic started. When the first pandemic first started, and we were doing it before we had any kind of funding. And so they were driving the conversations. And because we were having so many conversations and listening to, all the challenges, not that the challenges that the pandemic presented in isolation, just how it's impacting just their day-to-day decision making. And there was a value in that. So we were creating a list of partners, but we were also giving them voice in terms of how their needs looked in that particular situation. And each one of the counties had a separate and distinct set of challenges that needed to be brought to the table. And so we were really pleased with understanding who was on the ground doing the work, because a lot of that is we didn't want to come in if someone was already on the ground doing the work and how they were perceived. We were really intentional about how we selected our partners and community leaders. And a lot of this, and a great deal of this, was community driven. So if they said this is what they wanted in representation, we were okay with that. And so we just wanted to arm them with the right information that went out in the community in terms of how that would look. There was, some parts where there was some growing pains with the communications leaders because, you're getting this information out there, and I'll share that, I may have dropped the ball in assuming that everybody is on board for all parts of the project, right? And so as we were having these weekly meetings, there were about 18 community members. So I had 5 communications leaders, 3 community partners. And so with that representation, there was a sort of a hiccup, right? That folk were on board for the messaging around prevention, masking, hand washing, and all of those things. But when it came to vaccination, there was a different story, right? And so I assumed that the full team was on board. Then I noted that 2 of my communications leaders, they were not posting the vaccination messaging that we were given. So had a conversation in that meeting and understood that they told me, well, I'm still kind of on the fence about this myself. I was like, oh, okay. So we had to really go back and I had to go collect some information and do another phase of training with the communications leaders to make sure that I had to arm them with the right information, but I had assumed that everybody was just on board with all parts of the project, and that wasn't the case. And so we worked through it, and we got, we got full on participation, but I took for granted that everybody was on board with all parts of the information. And so this is what sort of letting people know who the community partners were in their community. This is a flyer that was done for Leflore County. And in that, we had a range. Again, you had Dr. Morris for this particular county, who was a respected pastor in the community. You had Ms. Hopkins that ran a beauty salon. So she was really engaged in how messaging, getting the narrative from folk that was coming in and out of her shop. You had 2 educators, and Ms. Johnson LaFleur and Ms. Sample, and a community, Ms. Jackie Hawkins, could help me pull together any group that I needed in the area because she has such reach in the community and such influence. So she was a community partner. that facilitated LaFleur. LaFleur had worked a lot better than the other two counties because they just had great energy together, and they could both be critical and but also be supportive. And so I want to get to the messaging. So the messaging again was tailored to the bi-directional part is we're putting information out, but we're collecting information on the impact and the process. But it looked really different, right? Because from some of the focus groups, when we really started at the height of COVID, a particular instance around, what people were feeling, there was a great deal of distrust. The president then was Donald Trump, and there was not a great deal of faith in rural communities around, and not just national our government leadership, but also at the state level as well. And so that showed up in the focus groups. And when we were talking about how residents, what do you think residents need? There was particular concern around the seniors, saying that they don't have smartphones and access to social media. And so we had to really kind of tailor those kinds of things. And so they wanted, churches to do more in terms of getting information out, because they felt like, the churches had such reach and pull that they were not leveraging that in a way that could really get information out. And they really didn't early on. There was just such skepticism around the vaccination and what was in it and how did they come up with that so fast. So all of those questions kind of showed up. And this is sort of a graphic that depicts that. That when they came out with warp speed, and then there was a presidential election, and then with the change in administration, then it moved to something else, right? It moved to now there is a higher level of trust in getting the vaccination, but then they started to feel like now we want the vaccine, but now we don't think it's being equitably distributed, in our communities. And so, they had this thing where residents were whispering, they want, seems like they want us to be asymptomatic. They want us to have symptoms in order to get the vaccine, but it looks like other folk, are getting it, without having to fit that criteria. And so there are a lot of conversations around messaging and how that had to look. But we were on the ground in many of those communities. This is what we were doing. We were giving out these care packages with hand sanitizers, masking, and just a flyer with some prevention measures on it. And we would be in communities handing these things out. So what you see on the far is we set up a little table and we had communications leaders that were issuing those out. That's our grad students at the time bagging all the hand sanitizers and supplies. We had t-shirts, and we did this in each one of the counties and giving them away. And because Mississippi is a red state primarily, there was kind of highly polarized, some people would turn it down, say, this is not real and all of that, you run into that. But most of the residents were really receptive to getting it. And so this is the breakdown of how the reach looked. So again, the communications leaders were, they had a log that they would keep. And so they would submit that log weekly in terms of what their reach looked like. This was from March to May, showing the impact of, getting them to submit. And again, online worship, we got the pastors to really kind of include that into their messaging and announcements and all of those different things. And so again, LaFleur County had really high numbers, Holmes County, and then Washington County. But there was still a great deal of impact in terms of getting messaging out. So if I were to talk about key takeaways, it was really important for us to have those weekly meetings between the communications leaders and those in each leg of the work. Also holding those listening sessions in each of the selected counties over extended period of time and preparing an environmental scan, because we didn't want to come in as an outsider trying to take over a particular space. We just wanted to collaborate and support. The listening sessions allowed us to build those relationships with community brokers that would introduce us and vouch for the program. Maintaining synergy within with the communications leader, because sometimes there was conflict, and we would have to talk through those things, because sometimes folk wanted to push their own agenda within the work that we were already doing, and so if it wasn't feasible, we just agreed that, maybe this isn't the best fit for you to be a messenger if you're not comfortable, and be okay with that. And so, but also as attitudes sort of shifted, it was interesting to see how the residents expressed concern about, the inequity and how the distribution happened, and how they felt like folk were coming into into their community, taking their slots for the vaccination. And so we wanted to take all those things into consideration. It was definitely a moving target, but it was a great opportunity for us to really get out there and understand how we could be supportive without being intrusive. And so with that, I try to keep it under my 30. And if you want this slide deck, this is my contact information. And that's what I have here. And so I'll stop sharing.
Fantastic. Thank you so much. I think that you really highlight such a success story, especially in regards to how difficult it was to promote communications throughout that whole process. So first up, we have time for questions. So please start to add those questions in the Q&A. While we're waiting for some questions to come in, do any of the panelists from our next session have questions for Dr. Washington? This might be a good time to ask that as well.
Right.
I had a question.
Yes.
I was curious about the social media part of extending these messages, and I was wondering, were the community leaders putting out messaging on their personal social media accounts, or was there a specific page where you shared most of everything, something associated with the university, or what?
Yeah, both and, right? And so initially we were giving them the information and they were putting it on their personal pages. And as we grew, we developed a COVID page, particularly for this work, where they could just grab all the information from there and post it on their pages. Another thing that they were doing within their groups, each of the communications leaders, they had their own thread. They used GroupMe and WhatsApp to communicate with each other during the week and pass along information. That was another really important part to keep them in sync. And so during the week, they would be on WhatsApp or GroupMe on their pages posting, or if they wanted to send each other something that they found, we would have to go through it, and it worked that way.
Cool, thanks.
Yes.
All right, we've got one question to be both seeking an answer. How did you find that community interests were the same across counties and age groups, or did they differ?
They differed a bit, right? So I'll start with Holmes County. Holmes County, there was more of an interest around how they are so socially isolated that, how do we start to get to those rural spaces, deeper out into the community? How do we even get messaging out there? Whereas Lafleur County was more interested in also Holmes County was more geared toward how does prevention look within households, in multi-generational households. But in terms of Lafleur County, it was really around the battle for equity, and how that it just seemed to them unfair how it seemed like messaging was driven to a population that they could not engage or tap into, or resources were being shared that they were unaware of. And so it was really about understanding where things landed and where are these resources in some of the counties, where others were just concerned about how do I stay safe. So, and also to answer your question, we have to develop messaging specific to each county each week. And that's why bringing the graphic designer was so important to help us filter that out, because they would see something that's like a print material, like a flyer, but it would have so many different points on it that they didn't want to follow it. And so with the circ model asks that you only do about 1 or 2 points on print material. and not overflow it with both prevention, vaccination, and then this, and then that, you know, and so split it out and just handle one thing at a time.
I have so many questions. This is so interesting, but I'm going to hold on my questions until the panel that comes later when you'll rejoin us. So please, thank you so much for that fantastic talk. We really look forward to chatting more in the panel portion.
Thank you.
Thank you. In the meanwhile, feel free to keep on asking your questions in the Q&A function. We'll continue to kind of come back to that. And also, I'm going to highlight a new feature for some of you folks. Let's switch this here. Okay, so hopefully you all can see that. So what we're looking at right now is something called a Padlet. A Padlet is essentially an interactive place where you can add your questions, comments, likes, and that sort of thing. So the folks from our team have been adding some really useful notes. You can look through this, and for example, if you found that the engagement component was super interesting, you can like that. As you like things, they kind of start to move up in the area here. You can also add your own question or comment. So for example, you just click on this bottom right part of the screen. I might want to ask, which rural community are you from, just to kind of understand like where all the folks are from today. So add your community in the notes. I hit publish, that shows up here, and then immediately you can see that you have an option to add a comment. So over here, we're in central Illinois, so it's kind of mixed urban rural area. Okay, and so we invite everyone to do the same. Feel free to comment on something that's already been posted. Feel free to ask a new question if you don't want to use the Q&A function, and or whatever other approach you'd like to do. Okay. All right, now I'm going to stop sharing for a moment and switch to, let's see here. All right, we're going to resume or kind of continue our workshop here. I'll move that, and I'll be chatting a little bit about the COVID Atlas project, what it is, what it can be used for, what has research with the Atlas shown so far, how can it be used to support your community. The reason that this is, I think, a really poignant full circle is that essentially the US COVID Atlas project started because back in March 2020, our team was then at University of Chicago, and we saw a lot of potential concerns emerging in rural areas, and especially how COVID was being reported in those early days. There tended to be a focus on large cities and places where just the total number of cases was being highlighted the most. However, as health geographers, spatial epidemiologists, and that sort of thing, we also know that sometimes areas that have less population overall may also have less infrastructure. So, and you might have to travel further to see your doctor. You may have to travel even further to go to a hospital. All of these factors made rural spaces especially vulnerable to a pandemic, to an infectious disease at this scale. So this is something that we had highlighted before. And also at that time, if you remember, a lot of the statistics that were coming out were at the state level. And we know that if a hotspot grows to the state level, it may be too late to contain it. So at least back in March 2020, there was still a focus on what was happening, or we were still hoping that we could potentially contain COVID before it could spread to those other levels. So long story short, this is the background of how the US COVID Atlas began. Today, it's a data visualization tool that provides access to current and historic health and vaccination data, community contexts, as well as clinic locations and state-of-the-art spatial methods like spatial statistics to define hotspots to help explore the pandemic. We were one of the first teams to kind of shout out the potential vulnerability of rural areas. It's one of the reasons that our project launched in March very rapidly, because especially some of the growing hotspots in Georgia, rural Georgia at that time, were something that we were really concerned about. By May 2020, we had already seen a 93% increase in rural places as opposed to urban places as far as cases per 10,000 people. And instead of looking at just total number of cases or total number of deaths, switching to population adjusted measures by just dividing by how many people there are in an area, really highlight the vulnerability of rural spaces, especially since March and April. So while there was a huge focus on what was happening in New York City at this time, we were also really concerned about what was happening in rural Georgia, for example. And especially following decades of hospital infrastructure loss, where a lot of hospitals in rural spaces were closed, this really made the landscape even more vulnerable to groups on average. Another thing that our group had done kind of early on, so because we were pulling county level measures and also applying spatial statistics to them live. So here you can see what's called a local Moran statistic. What you need to know essentially is that red counties signify that that county has exceptionally high rates of COVID. And its surrounding counties also have exceptionally high rates of COVID. And this is adjusted against the whole country. So for the whole country, in May 25, 2020, we started to see that this kind of hotspot that we initially saw in Georgia, there were also places across the Mississippi area, the Delta region, and Alabama that were also emerging as hotspots. By June, we saw that a lot of these areas were connecting. And for those of you who are familiar with some of the history of the South, there are a string of counties that are called the Black Belt. There's a long history behind that, following slavery in the US. So what we essentially saw was this connection. So in this area here, those areas with a slightly darker border are these Black Belt counties. These areas were kind of following a very similar trend. And as you can see over time, that starts to spill over to other parts of the South as well. These techniques and the tool that was developed was also really useful for other parts of the country. So here we see an area that in Wisconsin that has some large cities, but also a lot of rural spaces. We can see this progression of initially these blue areas are cold spots. Cold spots essentially mean that there's very few cases of COVID in those counties, and the surrounding areas also have very few cases. We go from a cold spot in the beginning of September, and then this rapidly starts to shift towards the middle of September from a hotspot in the Green Bay area to just a week later, pretty significant, substantial hotspot of COVID cases. And what was really interesting in this case, there were a lot of protests against the mask mandates in Madison. A lot of those folks were coming from parts of Wisconsin where they had not experienced the pandemic. So their experience locally made sense, but you can see how quickly the virus shifted that. And so one of the reasons that we're bringing in some of these statistics into the Atlas is because past work in HIV and opioid work from our team has highlighted how important it is to identify these places early to direct the intervention and programs that are needed. And there's many other cases like this throughout. We found that emerging trends and unexpected hotspots each have their own story, while the map is not going to tell you the story behind each of those. It will start to tell you where to look. So we use confirmed cases and 7-day average new case rates, or that's what we used throughout 2020, 2021, and then early 2022 to identify these places. And as you can imagine, if you shift to a different variable like vaccination, you can apply those same principles to understand where areas were needed to be focused or not. So there's a lot of data that's available within the US COVID Atlas. Folks will be adding the link to the chat so you can explore that in more detail. There's a lot of different approaches. Again, we can create what are called choropleth maps, or just thematic maps of the different data that you see. Just from shifting from state to county level, you start to see how where the cases or whatever variable you're looking at are pronounced. And if you switch to that statistical hotspot that I keep on mentioning, you can kind of confirm whether or not those areas really are statistically significant as compared to the rest of the country. Going to shift over here just to highlight what the COVID Atlas actually looks like when you look at it. So while we are still, some data may still be gathered after the end of 2022, a lot of the data that we're pulling from starts to end around the end of 2022, beginning of 2023. But you can see up here in the time slider that potentially you can scroll throughout the whole time period. What we see when you first go to the US COVID Atlas is the percent fully vaccinated, and this gives you a good idea of the variation and the tremendous heterogeneity of vaccination rates across the country. You can also see this time graph on the upper right-hand side, and all of this is interactive. So if you want to change the time slider, you'll see where you are in this time graph in that as well. To look for a specific place, for example, Lowndes County, Alabama, which has a lot of really important history associated with it, you can use the upper right-hand search tool that zooms you in, gives you some information. If you click on that county, pop up on a new sidebar emerges on the right-hand side that links dozens of not just COVID and vaccination details, but a lot of community health contacts. So we had partnered with county health rankings early on to bring all this information to you. So some of this will include things like average life expectancy for the area, self-rated health components, as well as things like what proportion of folks in this area are essential workers. So in this case, 61% is pretty high. We can use that time slider to look at that same information from a different time period. So this takes us to about the end of 2022, and I've changed to looking at confirmed cases in a population adjusted measure. And then I can move back 1 year prior to the peak of one of the peaks of the pandemic. And you can see, again, how dramatic the change is over that time. So we can see from this, there's many different views to the map. You can zoom in, you can zoom out. Here we're looking at the 7-day average case rate across the country from the end of 2021. We can also shift to a different visualization type. This can be really useful when communicating the differences across the country, because all red may not quite capture what the difference is. And then we can also look at different overlays. So here, there's an overlay called Black Belt Counties. You can find out more details about what that is specifically. And this is going to highlight specifically those counties that meet that criteria. Early on in the pandemic, some of our colleagues and collaborators used the Atlas for advocacy, for research, for a lot of different pieces. Dr. Lawrence Brown, who was then at the University of Wisconsin Population Health Institute, use the atlas as an advocacy tool, partnered with the NAACP in the Arkansas Delta area. So you can read more about that. We can share the link in the chat as well. We've also published a lot of research about this from the US COVID Atlas. So for example, previously we found multiple counties that had disproportionately high rates of mortality for over 100 days in the first year of the pandemic, that also kind of corresponded to different groups by racial, ethnic classification. And we found that whether or not you're in an urban or suburban or rural space, there was a significant difference on how you experience the pandemic, which is one of the reasons we're here today. In this map, you can see, again, if we're segmenting areas that disproportionately experience the pandemic, and we look at the same information, but highlighting where the non-Hispanic white population was, or the Latinx population, or the Black population, a lot of these areas. So here we can see in the A group, a lot of those Black Belt counties are identified here. In the B group, a lot of Hispanic and Latinx areas are highlighted. Many of these are indeed in rural places. So again, COVID-19 was certainly disproportionately experienced by the pandemic. There's a lot of different ways to learn how to use the atlas and read about how others have used it. We'll share these links with you in the chat in just a moment. And if you do use the COVID Atlas and wanted to get a little bump for yourself, we are still taking entries for a survey where if you've used the US COVID Atlas, you're reside in the US and you're an adult over 18, feel free to take the survey, tell us how it went, and we'll send you a $20 Amazon gift card to thank you. So at this point, I'm super excited to switch over to our panel discussion. Let me start to shift there accordingly. We are, oh, actually here, let's shift back for just a moment. Our panel discussion has a number of different leading rural health experts from across the country. We are going to first welcome our facilitator, Sarah. Sarah is a geographer and data journalist at the Daily Yonder. And the Daily Yonder is an independent publication about rural America. In 2022, she earned an MA in applied geography and geospatial science and a graduate certificate in GI science from the University of Colorado, Denver. While earning her degree, she served as the lead teaching assistant for the Department of Geography and Environmental Science. She was also the founding editor of Confluence, the department's first online journal. Sarah lives in Bakersville, North Carolina, with her partner, Hannah Marie, and their dog, Ernest. So please warmly welcome Sarah as our facilitator, and she will take it away.
Hey, everybody. Thanks for joining us here. Thanks, Marinia, for inviting me. Like she said, I have been writing for the Daily Yonder, we've been publishing weekly reports on the state of COVID in rural America at the county level since the beginning of the pandemic, using data from the CDC's community profile reports. Unfortunately, in February of this year, they stopped producing data at the county level on a weekly basis. And so we kind of stopped doing our weekly reports. But throughout our research and the last time that we did kind of a comprehensive report on the state of COVID in rural America, we found that there were over 200,000 rural residents that died of COVID, and that the rural cumulative death rate was 38% higher than the metropolitan rate. And so this is highlighting that, national inequality between rural and urban. We're going to get into some of the reasons why we think that is. But I just wanted to comment on the COVID Atlas because I'm really in love with how nerdy it is. It really reminds me of my days in grad school with some of the spatial stats and quant methods courses that I took. There's not a lot of people who can make those spatial techniques really accessible to everybody. And so Marina, I think y'all did a really good job of doing that, and you did a really good job of explaining that. And so, yeah, I think that's really cool. But I'm really happy to have this group of panelists here because I think you all look at health issues really holistically, which I think is especially important for rural America, because rural America's hardship with COVID, I think, has been blamed sometimes solely on vaccine hesitancy and booster rates and stuff, which is part of the picture. But unless you also address those longstanding health inequities that pre-existed COVID, things like hospital closures or lack of transportation, or Rodney mentioned broadband access, you don't really understand the full picture. And so I'm excited because I know that you all will provide some complexity to that conversation. But I want to start off by having each panelist briefly introduce yourself, your role during the pandemic, and in the spirit of reflection, you can answer the question, what is one thing you hope history doesn't forget about the pandemic? So introduce yourself, your role during the pandemic, and what is one thing you hope history doesn't forget? So who would like to start first?
I'll start. Can you hear me?
Yep, you're good.
Okay, great. Thanks for doing this. My name's Lori Francis. I really enjoyed Dr. Washington's presentation. I realize how triggered I still am by COVID. I just read a book by Louise Ehrlich called The Sentence that had a lot of COVID, and I realized I still have this reaction. So that's part of my introduction. When I was living through COVID in healthcare, I was the CEO of a federally qualified health center in Missoula, Montana, with 8 sites, and we served about 16,000 patients. I'm now the founder of a thing called co-op-leadership.com, which is working with directors around the country, leaders around the country, to affect change and not burn out. And I think that my perspective on living through COVID from the healthcare side is really intriguing to listen to Dr. Washington and know that all that work was happening because, as you all know, those of us in healthcare were drinking from a fire hose, and this sort of large disparities focused work we've been doing forever just kind of collapsed into this very narrow focus of how do we keep our staff safe? How do we keep patients safe? And it was really very focused. And then the pushback started with vaccines. So interesting to hear that the higher rates of death in rural America have a lot of complex reasons behind them. We experienced in Montana huge pushback, and for all the way from our state and federal government, obviously, but our attorney general going into hospitals and trying to force providers to do ivermectin and things like that. So going from really being the heroes in healthcare to being the villains was a interesting experience, I think, for all of us. And it's really uplifting to hear the work that Dr. Washington and others in the country were doing, that we were doing in Missoula in a much more challenged way, because we didn't really have a community-based force for good. We had a great public health department, but really all of us were so much in reactive mode that we couldn't, it took a year to really get out of that thinking. We did get engaged with this group, the COVID Atlas people, because after George Floyd's murder, we dived more fully into looking at our own subpopulation outcomes with COVID and everything else we were dealing with, and really found that the connection with the COVID Atlas people gave us hope and connection to a greater worldview than the one we were living. And it felt really sustaining for us to be involved in conversations around disparities in the country while we were looking at what was happening around poverty and racism and those disparities in Montana. What one thing, what was your question, sir? What one thing we take away? Or
Yeah, one thing,
Laura?
what's one thing you hope history doesn't forget about the pandemic?
What do I guess it's sort of a longer, broader upstream answer for me is what I hope is that we in this country and in this world do a better job teaching little children and big children about science and understand a little more about the human body and also human interactions, and how we can help all of us stay healthy, safe, and so I hope that our understanding of science grows and grows, and that we stop fighting back against the evidence. That would be my answer. Not very sexy, but true.
Yeah, it is true. Thanks, Laurie. What about you, Bill?
Yeah, thanks so much, Sarah. You can hear me all right?
Yep, you're good.
Great. And thanks, Dr. Washington, for that great presentation. I really appreciated hearing about your work. So I come to work in rural communities with COVID in a bit of an interesting route. So my work focuses on the harms that deportation can do in immigrant communities. And what we began studying when Trump was again elected was the impact of large-scale worksite immigration raids, right? So these are the raids in which dozens to hundreds of people are arrested. When I saw folks introducing themselves here, I realized, we traveled to many of these states to see the impacts of these worksite raids. Tennessee among them, Mississippi, certainly the largest set of raids that's ever happened in the US. But it was because of this knowledge of our rural communities and the impacts of these raids that we started thinking more about vaccine inequity, right? And how the immigrant community relationship to a US government that is trying to deport members of their family has direct impacts on how much they trust and access resources such as vaccines. So one of, when you think about, when I think about where the deaths most started occurring at the beginning of the pandemic, you'll remember where they were. Originally, it was in nursing homes, but then the next places that were hit were meatpacking plants, factories and prisons, right? And to me, when you think about the lessons, the history lessons of the pandemic, it is that we must think of individual behavior. Do we believe science? Do we get our vaccines? But we also, if we want to think about racial inequity, have to think about the big structural determinants, such as packing people of color, right, often men of color, in facilities like prisons and meatpacking plants, specifically to exploit their labor, and that these settings are not made to maintain health. They are not made to prevent infectious disease spread, right? So I think the story of the history of the pandemic is that it is not just about individual behavior change. It most certainly is about this, right? But it's also about the systems that constrain our ability to make these individual behaviors happen in the first place.
Thank you, Bill. And Rodney, I know you've already had your kind of introduction, but if you could just at least answer, the question is about what you hope history doesn't forget.
Yeah, so and everybody, I prefer Rodney. And so I really appreciate being a part of this panel. I think that for me, I would just like for us to see a more humanizing approach to health services overall, right? I talked briefly about how rural communities see access. Access isn't really access if you don't use that space, or you don't feel respected, or there's a lack of dignity in your approach, and how you see people, when they're in their biggest need. You're going in. I'm doing some work right now in Mississippi on looking at a dehumanization framework around how Black families see systems of care, like healthcare, health services, early childhood, and all of these, having access to these spaces. And in those conversations, many of them say they make a calculation on, is it worth it to go in here and be dehumanized just to get some assistance? And so when COVID happened, all of these things were already full blown in many of these communities. So why should I start trusting these systems now with something as deadly as this? So the trust had already been breached. It wasn't some way back historical thing. And so I hope that we understand that our system, and the other part of that, we assumed everyone had access. So schools shut down, right? And so we assumed every child had access to broadband and laptops and all of this stuff. And it wasn't the case, right? And so there were schools that were already underperforming with a significant drop in engagement from kids whose parents had to make all of these adjustments and all of these things. And so I think we need to really understand that there are some basic things that every household should have. It's not extraordinary to make a wish list like that. There's some basic things that every household should just have. Basic internet service should not be a fee, right? And so I think that when we look back on this experience, I think that we have to take into account that if we talk about, Lori and I were talking about early childhood, how important these developmental, these formative years are, we can't get them back, and it's a heavy lift to keep trying to work against that. So I think we need to really consider those factors.
Thank you. Laurie, did you have a question?
I had a thought that I wanted to add to this conversation. I didn't share, but and I don't have all of the data, but in Montana, there are at least 5 tribal First People communities. And the Blackfeet Nation and also the Urban Indian Clinic in Helena, Blackfeet is up in Browning near East Glacier. They had some of the highest immunization rates early on, like 95% immunized within the first couple months, while we in Missoula were struggling to get to 30 to 40%. And I think it very much had to do with the trust. So it was Urban Indian Clinic and the clinic in Browning offering its own people with a high degree of trust and protection. So I thought we were it was a great example of what trust and a really great strategy for getting immunizations into the bodies of the people that need them.
Yeah, that trust is a huge piece. I think that it keeps coming up with no matter what we talk about with COVID and talking to communities about public health. And I think this is kind of related. You've all kind of, I think, touched on it without actually saying the word social determinants of health, but I think I wanted to start the conversation with that concept because it's kind of a broad word, and I think it's healthcare professionals and public health experts, you can just kind of use that word without kind of really articulating what it actually means, because it kind of comes off as like it's just kind of everything. It's just your entire world. It's just like anything that happens to you or who you are. But this is a really important, part of understanding community health and risks. And so I think I want to start by asking if one of you who's better at articulating this concept than me could help me kind of reiterate what this means and why it's important.
I'm happy to try and have you all chime in. I was involved for the last 20 years in helping develop a prepared tool. Well, last 10 years, that probably, if you know the tool, you probably really don't love it. But and I think I'm curious what the other panelists say. I think that we've started using the term structural barrier, structural determinants. Social determinants sort of implies that people's socialization is it, not you, but that terminology. And I've started to not use that because it suggests, again, that if people would just pull themselves up by their bootstraps versus all the structural barriers we put in place for centuries in this country. So, but when you think about health and health outcomes, perfect healthcare would improve health outcomes by 20% at the most, more like 10 to 15. And all of the issues of poverty, racism, and classism, which are sort of the root of those. And then along with that and built on that and interacting with that is economic viability, educational achievement, housing status, having people who love you and care for you, having a family safety net. All those things are constantly and dynamically at play when for all of us. But certainly the laws and history of this country have created what's the word I want to say, sort of the basis for the disparities that we live with all the time. And by what Dr. Washington and I were saying, the thing that I think we mostly can agree on in this country, although don't fund, is that if we help people from the time they are pregnant until the time they come to kindergarten and really intervene at that point, we can make a big difference in health outcomes. Okay, other panelists, you guys can chime in and make that better.
Oh, Lori, that's a great way to describe many aspects of public health. So I teach a social determinants of health class. You're welcome to come join the first class. And that's a great overview. The phrase I like using the most is the social determinants of health are where we live, work, and play, right? And I think whether it's social determinants of health, political determinants of health, even environmental, right? So we're using these different phrases. And I think two things are important to remember there. One is, at the end of the day, what I really am trying to relay to folks is that it's not individual decisions. It's a lot of the things around us that shape our health, right? As Lori was saying. And the second is that it's often about, even in those terms, we sometimes don't use the words like power, privilege, and oppression, right? So it's often about who has power, who's making profit off the exploitation of whom, right? Going back to what I said at the beginning, what I mentioned at the beginning, lots of the pandemic was caused because folks were making profit off of the labor of folks who were heavily constrained, right? Both in things like vaccine access, but certainly where they could live, work, and play, constrained by things like poverty and economic circumstances. So I think that's one of the ways I would describe it. One of the best ways I heard it summarized in an article, and both Rodney and Lori have pointed to this element of trust that goes across all of the social determinants, right? But what we see in working often with communities of color, and one of the best ways I've heard described is it's not just about Tuskegee, as Rodney said, the man's the man, right? And Lori brings up the murder of George Floyd. Folks don't spend their time differentiating. Those are good police officers, those are bad. I don't trust ICE who want to deport me, but I do trust the police. And this just bleeds over into our hospital systems and our care systems, right? Which is in fact terrible, but does remind us that these systems, which we may see as unrelated in the lives of many folks, are very, very linked, right? The policing system and how much we trust it is linked to the hospital system and how much we trust it, right? So going back to the social determinants of health, it's the blending of those, of the SDOH in the lives of many of the folks in these rural environments.
Thank you, Bill. Yeah, that was good.
Yeah, I love those points that are made, because particularly I like to see social determinants of health in actual application, right? And so many of the residents that we speak with daily, like if we're saying that they should have healthier eating habits, but then they don't have access to healthy food spaces, right? And so we've learned that there's an over-reliance on like the dollar stores here, the dollar stores here. Like there's like one every 10 miles or something. And that's where they're going to get all of their fresh product that is not exactly fresh product, right? And so they don't have access to a specialist. They have access to, emergency room services. But it's disappointing to hear that because of where you live, how Mississippi is, we're centrally located, where Jackson is the hub for everything, right? So everybody's got to do that drive of about 90 minutes or something one way for specialists or some sort of service. So when you're doing a focus group and a pregnant mom says, if I go into labor, I'll take that 90-minute drive before I go to the hospital down the street because I don't trust that hospital. Those are things that we really need to look at, as we really unpack, what that means, where you live, work, and play, and how that interacts with your daily life experiences, where everything is an intentional decision, where we may take for granted this small thing, going to the store down the street. Everything is this intentional decision on how you're moving day to day for you and your family. And we have to consider that.
Yeah, kind of kind of building off of this same conversation, talking about if you structural barriers and racism and so on, then in March of this year, the Kaiser Family Foundation published a report on the disproportionate impact that the pandemic has had on people of color, and this has already been talked about a little bit. And so the report said age-adjusted data on American Indian and Alaskan Native peoples, Black and Hispanic people have had higher rates of death. That amid the Omicron surge, death rates for Black Americans were 38 deaths per 100,000 compared to 23 for white Americans. And in the way that I understand some of this data from talking to other public health professionals throughout my reporting on this topic is that rurality is only a factor that exacerbates those existing racial inequalities. And so, you know, if you're both Black and rural, then you might have double the risk. And so I'm just wondering if someone can help me think through, you know, how rurality might worsen health outcomes. Does it just build on the impacts of racism, or does it like compound that risk?
I could try and jump in there on that one. Also, I think when you look at these experiences I just mentioned, it has a definite impact on your health and help seeking behaviors, right? For African American communities, particularly when you're rural. There are some calculations that Black families will make, particularly in these rural spaces and with high poverty. You know, there's sort of a wait and see approach to, you know, whatever health outcomes they're sort of facing. And there's a calculation around cost. You know, they make a conscious decision, am I creating another bill? You know, and that's a real conversation within households. And so the spiritual side kicks in, you know, that's heavily ingrained in rural communities, particularly here in Mississippi, that I'm gonna, you know, pray about this. I hope that, you know, this will pass. And then it gets to a situation that becomes maybe, you know, it started as preventive something, but now it's something that's grown into something else, because the attitudes and normalizing that, you know, you may not get the best experiences, or you can't afford this health care, or, you know, or just some conditioning around how you see, you know, your health culturally. All of those things can sort of factor in. So it's not just being in the rural space. I think it is attitudes and generational kind of cultural things that develop out of those things that just carry on, you know, and how you see your health care. You know, I talk to Black men about their health all the time, you know, here, and it is always, you know, if I feel like I'm good, you know, why am I going to get a checkup? You know, and so we don't have those checkpoints like, you know, women do. You know, we just move accordingly, and we just hope everything is good until it's not. And so a lot of that is just how we need to rethink how we message out healthcare, particularly in rural spaces, but culturally and sometimes directed toward gender.
That's
I
interesting.
wonder.
Yeah, sorry, go ahead, Lori.
No, that's really interesting. I think that white men too, I mean, men don't seek healthcare and they don't want to know what they don't know, right? As long as they feel they'd rather not know they have, but Black men more so, right? So all the issues of racism. So I was wondering with, I mean, the data I think would suggest, and I'm speaking to the data experts, that racism is an independent factor in terms of health and well-being. And then the intersectionality of rurality and racism. I wonder if did we control because you guys looked at everything with the Atlas, did we look at, if you control for poverty, does rurality still have an impact? Whereas racism, I know, does, whether you're in urban or rural America, but does it, if you're not impoverished in rural America and Black, does it, or a
That's a
person
really
of
good
color?
question. Yeah. I am not totally sure.
I can
I don't
pipe
know
in here for a moment
yeah,
too.
for sure.
Just to add, so we also found that another challenge was age, especially a lot of rural spaces will have higher proportions of seniors, folks with disabilities. So, and also that intersection of aging and poverty can pose that kind of those additional threats. So I'll just add that there. But yeah, at the very least, you can explore that on the Atlas. And I can pull out a nugget from the last paper as well to be helpful.
Thanks.
And Sarah, if it's okay, I'd like to bring up two other structural factors that may
For
shape
sure.
shape health in these rural areas as related to COVID, right? So one is that many of our prisons are in these rural areas, and research shows that much of the spread of COVID-19 related to prison is both because the environment is, again, packing many people in, it's unhygienic, right? But also because prison guards are coming in and out from their communities, and because we're cycling folks in and out of jails, right? So every time someone is pulled over, every time. So we're cycling folks in and out of these facilities, and it's spreading into rural areas, right? The second is in many of these areas, and I come from Texas, so I've lived in a place that's predominantly Latino, and I live in Michigan now, where I'm not in statistical racial majority. And lots of the conversation here among Latinos and how folks end up in the detention system is about being racially profiled, right? When you're driving. And I'll remind folks that in many of the states that you're looking at now, driver's licenses are not, undocumented folks are not able to get driver's licenses. So there's this, I cannot drive. Rodney, you said this very well, right? You're weighing your risk. And when you're worried about being racially profiled because you're in a rural area and you can't get a license, you're just going to stay home, right? You're not going to go to, especially if you feel good, especially if you don't feel sick and you're going to get a vaccine. So thinking about this driver's license system and these systems of cycling people in and out of prison, those are often uniquely rural situations, right? So there is certainly interpersonal racism that's harming health. If we control for that, my guess is there's still these systems, these racist systems that would impact COVID-19 outcomes.
Yeah, thank you for highlighting that. I think that's probably one of the most profound examples of that structural part of the social determinants. And I can't believe I haven't thought before about how the prison system in, turning people in and out would impact the spread in rural areas, because they are predominantly in rural areas, and it's not like, the virus is limited just to the prison, the institution itself. Yeah, people are coming, going all the time. And so anyway, that, yeah, I hadn't heard of that perspective before. That was really eye-opening. So I think we're like 3 minutes over for this panel section a little bit, but I don't know if we have any other questions or anything, or what Rennie, you'd like to do next. But thank you all for joining me. And yeah, this was really nice to hear your perspectives, and thanks for sharing. So
thank you.
Nice meeting all of you.
Thank you everyone so much. And again, feel free to keep on adding questions to the Padlet. There will be so much to follow up on here. At this point, we're going to shift over to Mandela Gadri. So Mandela Gadri is a PhD student here at the University of Illinois Department of Geography. Just hold on a moment while I update the spotlight here. Thank you for your patience again. And we may go over just a few minutes, but again, that should work out pretty well. Okay. All right, so Mandela, I'll share the slides and take it away.
Okay, thank you very much. Yeah, and that's a very interesting conversation so far. Yeah, so my name is Mandela Gadri. I'm a graduate student in the Geography and GIS department here at UIUC. I'll be sharing with you our history project, which is led by a joint research team at University of Illinois here at Illinois and the University of Chicago. The whole idea around this, our history project, is to add a more human experience, that is, humanize the data that we have by adding stories and of people into what we already have. So that is what the entire project is about. And this is also very important for a number of reasons. The first one is to see how we can provide access to undocumented information. That is, things that were not captured quantitatively. So through the oral examples that we collect or stories that we collect, we are able to capture a lot of experiences beyond quantitative analysis. And we are also looking at providing information that can help improve the lives of marginalized communities through what is shared with us, and also create a platform that can help advocate for change in the public health system and in policy issues as well. A number of stories have been given so far, but even more important is that for those that contribute their stories, you have the right to, take down your stories at any time. So it is not like you just provide something that you can do anything about. So it's just one thing that you have to note for now. Like I earlier indicated, there are a number of stories that were given to us, and this comes in different forms, which is videos and audios and in a writing format as well. And this is an example of stories that were shared with us. You can see there a number of videos and things up there. So they just highlight a few stories that were embedded in the atlas so far. And then when we move to the next one, you see a more specific example of stories. This was a video that was shared on the impacts of the COVID-19 on families. And it provides a very good perspective of how individuals and families were impacted differently. And this was shared from Cook County in Illinois. And the next one that we talk about how the pandemic influenced communities. This can be in Cali towns or other communities that we have. And again, it's a video story that was shared, and it's provide very useful impacts. And this was also coming from us to us from Minnesota. And then we also have the writing section, and this also talks about how the COVID-19 creates some kind of isolation. And it's a very common thing that people were isolated from a number of people, the rest of the world and their families. So again, providing some highlight on how the COVID-19 impact family life. We have all of this in the stories as well. Now, how can you find the stories? If you want to go in and check on most of the stories, there are a number of things that you have to do. The first one is to click on the map icon that we have once you get into our page. And then you see this yellow icon that is up there on the top. Yeah, and then it's gonna pop up or populate the map with a lot of stories. Just click on it, and then you'll see a lot of videos in different formats to kind of see a lot of stories. And then you can also submit a story to us, and then which is by clicking on the submit button. You can also go through a number of processes that will allow you to submit your story. And this is one of the stages that you can look at, which is to, so once you click on share story, you sign up for an account. And then this is the process that is to take you through. You select how you want to show your story, and then it's going to take you to the next stage of how you can submit your story, in its form as well. So this is the third step. In the fourth step that we have, you now select how you want your story to be shown. Is it in the form yourself? Is it about your family? Is it about the community? And once you choose this option, you then move into the next stage, which is you beginning to record yourself or in any format that you want your story to be shown. Once you are done, you stop your recording, and it's going to ask you some basic questions about the county and then a few other questions. And then you agree to the line system that is up there, and then you hit submit. Then that is it. You have your story sent to us. We'll review your story once we get it. And these are the selection criteria that will be adopted for your story. You have to be in the US and be 18 years and above. And your story, once it's approved, you get a $20 Amazon gift card for the first, if you're among the first 50 submissions. And then once your story is submitted, is selected, you embed it in the story, in the COVID Atlas story. And again, it's very important to know that you have the right to your story and you choose to do whatever you can do with it anytime. You can remove it anytime you want. Yeah, so that is just a brief overview of the COVID Atlas story that we are doing currently. Thank you.
And thank you everyone so much. That essentially concludes our workshop today. We really appreciate the great conversation with all the panelists, the speaker, the members of the Atlas team, and thank you to all the participants for contributing your time, your ears, and your thoughts. So thank you so much. I'm going to stop sharing and just see if there's any final questions. All right, thank you again so much for all of your time. And we'll be following up by sharing the Padlet from today's session, a link to the live stream. So look for that in your email inbox. We'll also be sharing some of the resources that were discussed today. And feel free to keep in touch if you have any questions. Thank you, everybody. Bye.